Hello everyone, I am Dr. Saurabh Taneja and today we'll be talking about hypertensive emergencies. These are patients that we see routinely in our practice, both in emergency practice as in critical care practice. And we have it around us. Hypertension is a epidemic like diabetes mellitus nowadays, and more and more patients land up in the emergency with hypertensive emergencies. So we should all know about this, how to diagnose it, how to treat it, when to admit a patient in the ward, when to admit the patient in the critical care unit. Let's see and let's talk about it. So we'll be talking about hypertensive emergencies. I'll be talking you through a case. He's a 42-year-old male, known hypertensive since 1.5 years, on multiple antihypertensives. He's also known chronic kidney disease patient since 1.5 years, no history of prior dialysis, and a baseline creatinine of 6.5. He had a past history of mild COVID in 2020. He presented to the casualty with complaints of progressive shortness of breath since one day. He had a drop in urine output and bilateral lower limb swelling. His vitals on presentations are heart rate of 130, a blood pressure of 210 by 150, saturation of 88% on room air, respiratory rate of 30, and bilateral basilar crests were present on auscultation. He was started on non-invasive positive pressure ventilation, managed with diuretics, NTG infusion, given oral antihypertensives. His ABG was suggestive of severe metabolic acidosis with hyperkalemia. So, the typical patient who presents to our ICU, and this is an example of a hypertensive emergency. So, I just wanted to tell you how common these patients are in clinical practice. He was continued on NIPV support in the ICU, persistent hypertension on NTG infusion. Even he was not controlled on NTG, we used to use a labetalol intermittent bolus infusion along with that. We inserted dialysis catheter in arterial line to monitor the blood pressure. He needed dialysis and he improved clinically over time in the next 4 or 5 days. Another case, a 62-year-old female who's a diabetic since 25 years on insulin and hypertensive with 20 years on treatment. CKD for the past 15 years, hypothyroid for the past 10 years. The patient had bilateral lower limb cellulitis since December 2022 on conservative management and had obesity and obstructive sleep apnea. She presented to the casualty with complaints of inability to speak, inability to get up from the bed, altered behavioral pattern, and urinary incontinence since one day. There is a prior history of generalized weakness in the past 20 days. There is no history of fever, convulsions, or vomiting. On examination, her blood pressure was 230 by 108. When we admit the patient to the ICU, we realized that she had delayed responses to verbal stimuli, reduced power in all the 4 limbs, and slurred speech. We immediately activated the stroke protocol. The MRI brain was suggestive of small lacunar infarcts in the left periventricular area. Labetalol boluses were given for blood pressure control and she was started for infusion. On the ABG, we found that the potassium was 7.1. She was immediately shifted to the ICU. We had a nephrology consult, gave the patient anti-hyperkalemic agents. Fundoscopy is suggestive of no papillary edema and hypertensive retinopathy. And we planned for 2D echo, carotid Doppler, and Holter monitoring to find out the cause of this stroke. So, these are the patients who present to our critically care units as the patients with hypertensive emergencies with an end organ damage. So, patients can have a high blood pressure and present with organ or without organ failures, and that is where we should be very careful in how we manage these patients. So, severe increase in the blood pressure associated with acute hypertensive mediated organ damage, which is called as AHMOD, acute hypertension mediated organ damage to the end organs like heart, brain, retina, kidneys, and the large arteries. So, if these are present, we call them as hypertensive emergencies. Usually, these patients have a systolic blood pressure of more than 180 and a diastolic of more than 120. However, lower thresholds can be associated with hypertensive emergencies in the case of swift elevations from lower baseline blood pressure. So, usually these patients have a 180 more than 120, or the blood pressure increases very swiftly from a lower baseline. And these patients have a acute hypertension along with the organ damage. So, these are the patients who are called as hypertensive emergencies. Remaining patients with elevated blood pressure but without this AHMOD, no organ damage, are named as severe uncontrolled hypertension. So examples of end organ damages are hypertensive encephalopathy leading to ischemic stroke or intercerebral hemorrhage, subarachnoid hemorrhage, acute aortic syndrome, pulmonary edema, severe preeclampsia or eclampsia, pheochromocytoma or adrenergic crisis, acute renal failure, or a malignant hypertension. So these are all the examples of acute life-threatening end organ damages. Now we have to distinguish between the two. Why is it so important? So patients who present with a hypertensive emergency. So these are patients who are having a higher BP as well as end organ damage. They are managed by pharmacological and non-pharmacological interventions for lowering the blood pressure. And in these patients, we have to be very careful. We have specific treatment protocols and they need intravenous drugs to titrate it to prevent the end organ damage. And they have conditions like acute coronary syndrome, ACS, acute heart failure into pulmonary edema, acute aortic syndrome, hypertensive encephalopathy, a stroke, preeclampsia or eclampsia. So these are all the patients which form a subset of admission to our critically care units, and these are admitted to the ICUs, have to be monitored and treated with intravenous agents to prevent the end organ damage. Whereas patients who don't have end organ damage, they do not require admission to the ICU and can be managed either in the wards or at domiciliary treatment by reinstituting or intensifying previously prescribed antihypertensive drug therapies. So they don't need a critically care admission at least. Now, what are the predisposing factors of hypertensive emergencies? First is a low adherence to antihypertensive drug therapy. So patient is already on a blood pressure lowering medication and he stops taking it. Discontinuation of a BP lowering drugs due to some reason. Abuse of illicit recreational drugs leading to increased blood pressure and sympathetic stimulation, and poor control of common risk factors over a long duration of time like smoking, obesity, diabetes mellitus and hypercholesterolemia. So these are the very common predisposing factors, and if you look in our community, we will find many people, many known tools who are having these risk factors. So we should all take care of them and ask them to check the blood pressure regularly and adhere to the antihypertensive medications that they are prescribed. And what can be the common presenting features of these patients?